Good day. I'm Al Powers. I'm the director of the Vanderbilt Diabetes Center, and I want to welcome you to this week's edition of the Diabetes Research Center's virtual seminar series. This is something that the 9 diabetes research centers shown at the bottom of this slide started as the COVID crisis began as a way of connecting scientists and talking about important issues related to diabetes research. It's been a really outstanding series, and this today is the 12th speaker in this series, and we'll introduce Dr. Gonzalez in just a moment. But I wanted to thank all the people who have attended, and also thank the diabetes research centers who have given their ideas and volunteered speakers and their attendees. We're going to reconvene this series in the fall in September, and at the end of this session we'll give you more information. So thanks for being there, and we're delighted to introduce Dr. Earl Chambers, who's at Albert Einstein, who will serve as the moderator and introduce Dr. Gonzalez. Earl.
Thank you very much. Welcome everyone. My name is Earl Chambers. I'm the director of the Division of Research in the Department of Family and Social Medicine at Albert Einstein College of Medicine in the Bronx, New York. I'm also director of the Population Health and Health Systems Core of the New York Regional Center for Diabetes Translation Research. It is in this capacity that I work very closely with our esteemed speaker this afternoon, Dr. Jeffrey Gonzalez. Dr. Gonzalez is professor of psychology at Yeshiva University and professor in the Departments of Medicine and Epidemiology and Population Health at Albert Einstein College of Medicine. He is also director of the New York Regional Center for Diabetes Translation Research. His research interests are in diabetes self-management and psychosocial aspects of diabetes. His NIH-supported studies have focused on longitudinal investigations of the relationships between diabetes self-management, glycemic control, and emotional distress in type 2 and type 1 diabetes, and on interventions to improve treatment adherence and depression management in adults with type 2 diabetes. Dr. Gonzalez is a fellow of the Society of Behavioral Medicine and the Academy for Behavioral Medicine Research, and is past co-president of the Behavioral Research in Diabetes Exchange, or BRIDGE, Professional Society of Behavioral Health Researchers in Diabetes. I'm excited to hear Dr. Gonzalez's presentation, Tangled Up in Blue, Depression, Distress, and Diabetes. But before Dr. Gonzalez begins his presentation, I would like to go over a few logistics. We will have question and answer after presentation. To ask a question, please click on the Q&A icon at the bottom of your Zoom screen, and then type your question in the box that pops up. At the end of the presentation, I will ask those who have asked a question to raise their hands. You can do this by clicking on the raise hand icon in your Zoom controls. When I call on you and open your mic, you will still need to use your own Zoom controls to unmute your microphone. If you don't have a working microphone, just note this in your question so I can read your question to the speaker for you. Please be patient. We will try to get to as many questions as possible. With so many participants, we may not have time to field every question. Okay, without any further ado, I would like to welcome Dr. Jeffrey Gonzalez.
Thank you, Earl, and thank you everyone for inviting me to be part of this seminar series. As was just said, this is the last one for before we go on our summer break. So I thought I'd try to take a little bit of an opportunity for fun, at least for myself, and disclose that the title here is really inspired by a song, Tangled Up in Blue, by Bob Dylan on his Blood on the Tracks album, and this was released a couple of years before I was born. But believe it or not, I think it's relevant to our conversation today, where in this song, so many different perspectives were taken from first person to third person, back again. A series of scenes are described to talk about the relationship between these starstruck lovers. And all of those shifts in perspective, jumping back and forth in time and switching locations across the narrative really makes the listener aware of perspective itself and how perspective can shape our perception of things, and maybe having a muddled understanding of things as complicated as human emotion is kind of the best we can hope for. So It also, I think, is relevant because it's a good description for what it's felt like for me to be tangled up in this literature over the years. I've been working in this area related to depression and diabetes probably for the last 14 or 15 years. And so I'm hoping that we can wade through some of the evidence together and tie up some loose ends and see if we can come to some conclusions. But we're dealing with a difficult topic, and I think that's why things are a bit tangled up. I'm gonna give you an overview here. We'll talk about depression and diabetes, focusing on prevalence and associated risks. Then we'll talk about some intervention findings. We'll spend a good deal of time talking about measurement issues because I think that these have relevance to how we conceptualize the problem and also inform our approaches to practice. We'll touch on some unanticipated problems with screening programs for depression. We'll distinguish between depression and diabetes-related distress and discuss why that distinction is important. And then we'll briefly just touch on social determinants of health and context and how that might fit in here. And then we'll end with a touch on implications, recommendations, and future directions. But if we want to start at the beginning, we have to go all the way back to Sir Thomas Willis, famous for describing the circle of Willis in your neuroanatomy classes and the cranial nerves, also famous for coining the term diabetes mellitus. And I learned from Richard Rubin years ago that it was actually Sir Willis who first posited the idea that sadness or long sorrow generates or foments this morbid disposition in referring to diabetes. And modern research has shown that Sir Willis was onto something with his clinical observations. This is a meta-analysis that's sort of hot off the presses, and it looks at studies that measure depression either by depression symptom severity scales in the top part of the graph here, or by exposure to antidepressants. And regardless of which way depression is assessed here, there's this consistent and meaningful relationship between depression at time 1 and risk for the development of type 2 diabetes over time. There are now numerous meta-analyses that consistently show that patients with diabetes are at an increased risk for the development of depression compared to people who do not have diabetes. And depression is consistently related to poor glycemic control, risk of complications, and increased risk of mortality. And these studies have all been largely consistent. These are meta-analyses that I'm citing here. There are even newer meta-analyses that focus on longitudinal relationships. And so that set of compelling findings has encouraged investigators to focus on doing something about this and seeing if we could treat depression to improve outcomes in diabetes. There's a limitation with this literature. There are several, but one major one that we'll touch on today is that it tends to focus on major depressive disorder as the construct that explains these relationships, that underlies these measures of depression. But the measurement methods that are used by these studies are often poorly equipped to identify depression with the kind of accuracy we'd hope for. And we'll get into that. But it doesn't take a rocket scientist, it doesn't take a PhD in psychology to think that the symptoms of depression that we are all familiar with, including depressed mood, fatigue, changes in appetite and weight, feelings of guilt, worthlessness, low self-esteem, concentration or memory problems, that these very symptoms of depression could complicate the already demanding tasks of diabetes self-management. So this has been one pathway that I've been interested in understanding depression's relationship to poor outcomes in diabetes, and it was kind of my door into this kind of work. Back in 2008, we published a meta-analysis in diabetes care where we looked at all studies that had a measure of depressive symptom severity and some measure of diabetes self-management activities. And we found in our overall analysis there was a significant and sort of medium effect size in the small to medium effect size range that was robust across studies and moderators, and that suggests a consistent relationship. We see it across various domains of diabetes self-management, significant in each of those cases except for foot self-care, where we really had just a couple of studies available at the time. So the strength of these relationships and the plausibility that depression's link with these outcomes might reflect a causal relationship has led to a number of investigations that have sought to evaluate what happens to diabetes control when you treat depression. And there are now enough of these papers to support meta-analyses of this literature. And here's just one example looking at SSRIs, the most commonly prescribed antidepressants for depression today. And we see that across different drug classes here, this is Prozac or fluoxetine at the top here, across these different drug classes, we see consistent relationships between treatment with antidepressants and improvements in glycemic control. I'll point out this is a standardized mean difference, so we can't interpret that in HbA1c units. Sometimes the endpoint here was fasting blood glucose, sometimes it was an A1c, but this gives us a sense that there is a meaningful effect on treatment of depression with antidepressants on glycemic control. It does not conclusively tell us that that benefit is due to improvements in depression symptoms per se. And just a little caveat here, we won't have time to go into that too much, but this Echeverry study is significant in that respect because yes, they did find a positive benefit of antidepressant treatment on HbA1c in their study of adults with type 2 diabetes, but they did not find any positive effect on depression symptoms in that same study. So whether these benefits in glycemic control are really due to improvements in depression is still not exactly clear. This slide, I know, is not exactly clear. There are a lot of studies on here, 70, and this is another meta-analysis that's kind of hot off the presses here by Winkley and colleagues who looked at psychological interventions, so not medications this time, but things like cognitive behavioral therapy, motivational interviewing, other psychological approaches, and looked at the effects of those approaches in randomized controlled trials on glycemic control. Again, we're looking at a standardized mean difference here, not HbA1c units, but we can see, yes, we have a 0.13 small effect size here that is statistically significant, but suggests that these psychological interventions, while not only having effects on positive effects on depression, could also lead to effects on improvement in glycemic control. We have another caveat here, though, that I'll point out just because I know the guy. This Steve Safran et al. 2014 was a paper that I was part of. You see it's a small sample comparing 45 individuals randomized to the depression treatment intervention and 42 randomized to the enhanced usual care intervention. We'll talk about it a little bit more in a slide or two, but that was an intervention that involved a good deal of adherence training and support for self-management baked into the integrative depression treatment. So I think that gives us a little bit of caution about, again, whether we can ascribe changes that we're observing here in glycemic control to changes in depression. I think one thing that we can be clear on is that evidence does not support the expectation that treating depression will improve diabetes self-management. Studies that have looked at adherence or other self-management measures as outcomes of depression treatment have generally not found positive relationships. And we have our fairy godmother here because I think that is a little bit like having an expectation of a magic wand, that we treat someone's depression and suddenly they become experts at diabetes self-management. That may be necessary, but not sufficient. The exception to the rule here is that Safran study that I pointed out on the prior slide, and I think this is a good example of an integrative approach to depression where we put aside the scientific rigor that would be necessary to really isolate changes in depression as the explanatory pathway for any benefits in glycemic control or self-management by integrating behavioral intervention skills that were targeting self-management directly with those that were targeting depression. And what we found were pretty consistent positive effects This MEMS line here is for electronically monitored medication adherence. We saw a difference between the groups at 4 months of treatment, at the end of 4 months of treatment, of about 20% of their doses being taken more frequently among those who got the full treatment here. Similar benefits for self-monitoring of blood glucose. These are clinician-administered clinical interviews for depression severity. Those are also clinically meaningful differences. And finally, we see a 0.7 unit difference in A1C at the end of 4 months. These were all positive effects, but I think are probably standing out in this literature because of the extent to which we integrated self-management, education, and support into our depression treatment program. And these effects were mostly maintained over our 12-month follow-up, except interestingly, depression severity, which again may speak to the independence of these outcomes. So we'll get into some measurement issues here. And again, I think some of these measurement issues that we'll talk about really reflect the complexity of the problem under study. So there are a variety of plausible biobehavioral mechanisms that could link depression and, in this case, type 2 diabetes, but could also link depression to poorer outcomes in type 1 or type 2 diabetes. And those include health behaviors, the diabetes diagnosis itself, which we'll touch on in a second, disease-related factors like obesity and vascular complications and drug therapy exposures that may complicate the picture, as well as biological mechanisms around subclinical inflammation, the HPA axis, sympathetic nervous system, and the central nervous system being dysregulated in depression in ways that may link up with impairments in glucose regulation. So for me, one kind of fly in the ointment in this literature that really suggests something important is reflected in this slide, taken from a meta-analysis a little bit about 9 years ago now. And these investigators pulled together studies and compared those with normal glucose metabolism, impaired glucose metabolism, and undetected type 2 diabetes in this first panel here in terms of their odds for having significant depression. And what this first panel is telling us is that there's no differences between these groups in terms of their risk for depression. But when we move over here to include individuals who were diagnosed with diabetes prior to participation in these studies and knew about that diagnosis, those are the folks who have increased risk of depression, and they have significantly increased risk even relative to those who are undiagnosed and unaware of their diabetes, but who satisfy diagnostic criteria. We did an analysis similar to that for the Diabetes in America book that was updated a couple of years ago by NIDDK. It's free to download online. I'm going to point you to it at the end of this talk for more information. But here we were looking at individuals in the NHANES cohort who had diagnosed diabetes, undiagnosed diabetes, or prediabetes, and we're comparing all those groups to the group with normal glucose metabolism, but here we're comparing them at the level of individual symptoms of major depressive disorder that are captured by the PHQ-9 screening measure that was used here. And what you can see with all of these stars are significant differences between those with diagnosed diabetes as compared to those with normal glucose metabolism at the level of each of these symptoms, whereas the picture is much more spotty with just a couple of borderline significant effects when we compare undiagnosed diabetes and prediabetes to normal glucose. Now things are tangled up here. Disease is advancing among those with diagnosed diabetes and is more likely to be at a more advanced state, and also treatment is being initiated. So the burdens of health and treatment are mixed up in these data, and so that at least suggests that maybe there's something about diagnosis and treatment that's important to consider in understanding this risk for depression. Here's a meta-analysis that's also recent and looked at a number of studies that compared individuals who were on treatment regimens that included injectable insulin to those who are managed by oral medications or diet and lifestyle changes with type 2 diabetes. These are all adults with type 2 diabetes. And what we're looking at here is the increased odds of depression among someone taking insulin in these studies. Overall, we see about a 41% increased risk of depression among those on insulin as compared to those on other oral agents. So this again may speak to the burden of treatment, but could also reflect poorly controlled diabetes and advancing diabetes. This other study from Germany, the Gutenberg Health Study, used an even larger population than we had available in Haynes, and they looked at individuals with, these are all adults, individuals with type 2 diabetes and those who did not have any diabetes. And they compared those groups again at the level of symptoms, not at the total score, not at reaching a cutoff for likely significant depression, but at the individual symptoms themselves. And what they found was that it was only somatic symptoms that differentiated those two groups. Feeling tired or having little energy, problems with appetite or overeating, moving or speaking so slowly, or the opposite, being fidgety and restless. These are symptoms of major depressive disorder, but they're also symptoms of dysregulated blood glucose. And they could be indicators of poor health that may be even less specific to diabetes. This, I think, points to a potential confounding issue here in how we assess depression and how much somatic symptoms are part of that assessment. So I think we have a chicken and the egg problem here. Which came first? Emotional distress may cause worse treatment outcomes, and that could be through poor self-management and treatment non-adherence, a behavioral pathway. It could also be through biological pathways like systemic inflammation, sleep disturbance, and HPA axis dysregulation. I think it's also plausible, and there's evidence to back up the idea that diabetes causes emotional distress, and those pathways could be through treatment burden and side effects like hypoglycemia, or through poor health and functional limitations that go along with poorly controlled and advancing diabetes. It's also possible that common factors are driving both of these phenomena, and they're related to each other only through their relation with these common factors, whether we're talking about socioeconomic deprivation, poor education, exposure to unhealthy foods, these kinds of things. And then confounding is another possibility, especially with respect to somatic symptoms. These aren't challenges that most studies are able to overcome in the methods that are typically used. But I'm lucky to know Andrea Charrington from UAB, and through partnering with Andrea, we were lucky enough to have an emotional distress sub-study funded through an R01 as an ancillary study to the GRADE comparative effectiveness trial that's going on at a lot of your sites, I know, and is currently underway. For those who aren't familiar, this involves taking people with type 2 diabetes who are early in the course of their diabetes, only exposed to metformin, no other glucose-lowering agents. They're put through a metformin run-in to get onto a maximal dose, and then they're randomized to 4 different classes of medication that you can see here. They are then followed over time, over a follow-up of up to about 5 years, and they're followed for primary outcomes in terms of A1C crossing that 7% threshold, and secondary metabolic and tertiary metabolic outcomes, as well as other outcomes that aren't listed here. And then there are decision rules to really try to objectively as possible, compare these 4 treatment arms. There are decision rules about intensification of therapy. Now, what our sub-study is going to do is it's going to capture, and it's been capturing, about 1,700 of these participants assessed on quarterly or biannual basis, and we're able to assess them for depression, distress, medication adherence, self-management, and related constructs, and hopefully be able to tease apart some of these directionality issues while taking advantage of the strong control of random assignment for treatment regimen. So we're excited about that. We're open and hoping for interested collaborators, and I think these are data that will be coming over the next few years. So screening for depression, that is something that we'll touch on next, and it's also a measurement issue. This sounds like a good idea to just about everyone, and I think with the right parameters, I think it is a good idea, and it's something that is increasingly recommended as part of standards of care for hospital practices, for primary care practices, and specialty clinics focused on diabetes care. But there is a little bit of a tangle here where the simple administration of self-report screening measures for depression is not enough to address the problem at hand. And I think the guy who really started my problems with respect to this research is Larry Fisher, who in 2007 published these data for adults with type 2 diabetes, where he did the gold standard structured clinical interview to arrive at a diagnosis. And then he also gave people a very commonly used depression screening measure, the CESD scale, which typically has a cutoff of 16 or above for identifying caseness for clinical depression. And that also sometimes is used with a more conservative cutoff. And what you can see first off is that the prevalence really varies depending on which one of these you think is telling you about the presence of clinical depression. And if we compare the two screening cutoffs to the gold standard diagnosis, we see that the majority of patients with positive results, the majority of patients who will be positive in screening programs, and the majority of patients or research participants who are identified as depressed in the research literature on diabetes and depression are actually misidentified. They're false positives. Larry more recently published similar data, this time using the PHQ as a screening measure rather than the CESD, but a very similar story here in type 1 diabetes, where the majority of positive screening results are going to be false positives who do not qualify for a diagnosis of clinical depression or a psychiatric condition. I think this is important for deciding about treatment, and also, again, as I mentioned on the previous slide, for understanding some of the limitations in a literature that identifies a group with depression based on a screening result this way and compares that group to a group that does not meet the screening threshold. So how would this work in clinical practice? Well, there's a good review available, there's a good meta-analysis available for a long time now that suggests a baseline prevalence of about 9% for major depressive disorder in adults with diabetes. And if we take that as a starting point and look at results from a review of screening measures that have been used for depression and diabetes and come up with a estimate for screening sensitivity and specificity based on that review, and we decide to screen 1,000 individuals in your practice, we'd have 365 positive screens through this program. Only 73 individuals would have true MDD, and 292 would be false positives. We'd miss about 16 false negatives through this procedure as well. So what do you have to do to get at least to the point of a flip of a coin, right? Where you could flip a quarter and have a 50-50 chance of the person who had a positive screen on one of these measures actually being a true case of major depressive disorder who could likely benefit from treatment or intervention. Well, you have to live in a pretty depressing place, and I hope we're not all heading there these days with everything going on. But you need a baseline prevalence of about 28% to have a 50-50 chance of false positives to false negatives. To false positives to true positives. And you'd still have a small number of false negatives. So the reason why I'm dwelling on this is that we have limited mental health resources to meet needs of patients who have already been identified. And such programs could greatly increase the need for mental health evaluations to tease apart whether people are true positives and false positives. And I'm not sure that's the best use of our resources. So pretending everything is fine, I just love this little guy's face here and try to work him into my talks when I can, because he just seems like a real happy guy, not a care in the world. You know, just the face that I'd like to be feeling just about all the time. But his expression doesn't tell us the whole story here. And he's actually in a bit of a predicament, even if we can't tell that by looking at him. Maybe even if he can't tell that himself. So maybe he's a metaphor for our patients with diabetes who are depressed and don't know it, or who otherwise are not willing to share that with their providers. And maybe this is a metaphor for the importance of screening. But I think it's also a metaphor for all of us as healthcare providers in the way we pretend that we have an adequate mental health system to meet the needs of patients we'll identify. So many of you, I'm sure, have seen the movie or read the book, One Flew Over the Cuckoo's Nest. And this headline, I think, is just really apt here, not just for the hospital that the book and movie were based on, but for what's become of inpatient mental health care in this country over the last several decades. Most inpatient mental health hospitals are now museums, or they're in ruins, or somewhere in between those two. We've also seen a scarcity of specialized mental health services when it comes to psychiatric and psychiatric care, as well as care from psychologists and other mental health specialists. The availability of these providers really varies across the country in rural settings versus city settings. This one study was focused on city settings that have plenty of psychiatrists: Boston, Houston, and Chicago. They called 360 of them, were able to reach 33% of them on one round of calling. About another third of unanswered calls were returned. And after 2 rounds of calling for appointments, they were able to secure appointments from 26%. And they did not find that payer type was associated with any of this. Importantly, the average wait time was 25 days, and they conclude results suggest that expanding insurance coverage alone may do little to improve access, or worse, expansion might further overwhelm capacity. So I think that's a word of caution for us about some of the unanticipated consequences of screening programs. We know that antidepressants are being prescribed with growing frequency over the last 30 years in this country and other Western countries. What this graph here tells us, looking at percents of visits during which an antidepressant was prescribed from a large database, we see that over time here, the amount of antidepressants that are prescribed to those who do not carry a psychiatric diagnosis is really what's growing most rapidly, right? So these are care visits that are happening in offices other than those of psychiatrists. So these are predominantly primary care, internal medicine providers, and other non-mental health specialists who are prescribing antidepressants without even needing a psychiatric diagnosis. That's unlikely to be helpful to patients based on the literature that's available about the effects of antidepressants in subclinically depressed people. So here's the joke. Of course you feel great. These things are loaded with antidepressants. And we are, these drugs are by and large relatively safe. We've been using them for a long time. We know about their side effect profiles, but the side effects are not nothing. So we have GI side effects that might already be problems for people taking medications for diabetes. We have sexual dysfunction that may be a concern for patients with diabetes. Weight gain can happen with some drugs. Other drugs cause weight loss. There are some question marks around suicide risk for some of these drugs, particularly among adolescents and young people, although there's some controversy there. And certainly, and in many communities still, there's considerable stigma around taking antidepressants and other psychotropic medication, and stigma involved in being labeled with a mental health condition, not to speak about the financial costs and the potential for medicalization of issues that really reflect social, relational, psychological problems. So it's not all depression. Here's Bob again. And we all know about the old saying, if the only tool you have is a hammer, then everything will look like a nail. Well, sometimes no matter how hard you bang your hammer, things just aren't going to come together unless you have the right tool. Not everything is depression, and we know that the treatment regimen that goes along with living with diabetes is burdensome. We're talking about long-term persistence with adherence to medications, a whole bunch of lifestyle changes, self-monitoring, foot self-care, going to medical appointments and getting preventive care and screening, managing co-occurring illnesses, and day-to-day problem solving. If you've talked to someone with diabetes, you've heard about the decisions that need to be made about things that went one way yesterday and a different way today. And when experts have gotten around to actually think about how much time would people need to spend on the things we ask them to do, they've estimated that we're talking about over 2 hours a day spending on diabetes self-care. So diabetes-related distress has been a construct that's been developed over the last 30 or so years that has been increasingly gaining prominence in the literature as representing emotional distress specific to the burdens of living with diabetes, its treatment, and self-management. There are a couple of validated scales that are widely used in the literature. There's a type 1 specific version for the diabetes distress scale now. I'm putting up the 2 items from the 2-item screener that is also available and validated. And a meta-analysis just a few years ago estimated that about 36% of adults with type 2 diabetes report elevated diabetes distress that could be clinically significant. So why is this important? Again, Larry showed this in that early paper that gave me pause, where he had that gold standard assessment of major depressive disorder, but found that it was really diabetes distress that was most closely associated with HbA1c, calorie consumption, fruit and vegetable servings, and depressive symptoms based on the self-report screener were additionally related to fruit and vegetable servings and physical activity. However, major depressive disorder showed no significant relationships with any of these parameters. This one that's asterisk there is actually below the level of significance. So when major depressive disorder is assessed with the best tools to evaluate it, we find a different picture than we seem to find when we rely on self-report measures of symptoms of depression. Larry's work also showed that both depressive symptoms that are subclinical and diabetes distress that also does not represent a psychiatric condition are common, more common than major depressive disorder, and that they're also more persistent over time in this 18-month follow-up than major depressive disorder was. There's also a gradient with treatment regimen complexity here, where adults with type 2 diabetes who are on diet or oral medications reported significantly less diabetes-related distress than those taking insulin. Again, remembering the caveat that this could represent advancing disease or more burdensome self-management. This is a paper that I published a few years ago where we tried to really get into the weeds here and look at somatic symptoms of depression and cognitive and affective symptoms of depression grouped separately. And that's what you see here for the PHQ-9S, that's somatic. And then this is the cognitive and affective symptoms. And here we're looking at electronically monitored medication adherence. And let's just focus on that, even though we did have a measure of self-reported medication adherence as well. What we found here, whether we were talking about the self-report PHQ or a clinician-administered MADRS clinical interview, we found that it was really the somatic symptoms that were captured on these scales that were most closely associated with non-adherence, and the cognitive and affective symptoms like loss of pleasure, low mood, the cardinal symptoms of depression were actually not significantly related at all with non-adherence. When we included diabetes distress into these models, this either resulted in the diabetes distress scale having a significant relationship or just a borderline non-significant relationship, depending on how many of these somatic symptoms were controlled for. The PHQ captures more somatic symptoms than the MADRS. But overall, this, I think, is telling us that maybe the difference between symptoms of depression is worth paying attention to when we're predicting outcomes in diabetes. Again, this could have implications for the types of interventions we develop if these are causal influences. So do we know what we're talking about? I think it's important for us to recognize that there is an overlapping set of constructs here, both at the level of how we think about them and how we measure them. Clinical depression is real, it's important, it's under-recognized, it should be treated, it can be treated effectively. But there is also diabetes-related distress that is more common, more chronic, and not well matched to the treatments that we have for depression. Life stress and social determinants of health can overlap on all of this, as can other psychiatric disorders that overlap with clinical depression, and somatic symptoms that overlap with clinical depression but may be more indicative of problems with health than they are indicative of depression per se. So the lines from the end of Tangled Up in Blue summed it up like this: we always did feel the same, we just saw it from a different point of view, tangled up in blue. And I think we're all tangled up in a lot of emotions these days. This is just a meme, I guess, that I saw and stole from Facebook, was shared recently. And I think it's a sign of the times and what we're all, many of us are feeling distressed, stressed, but not all of us are feeling those things about the same things. And I just want to pause here with this scene from recent protests from downtown Minneapolis, where Dylan was born in Minnesota, and this is right in front of the mural that says the times they are changing. That's referring to a song written even longer ago, 56 or so years ago, but it's still relevant today with the streets filling with people who are clamoring for changes. And I think that this little stop off here is meant to emphasize that psychiatry, psychology have never done a good job at explaining social problems like this. And I think that there is a risk, whether we use the label depression or we replace that label with diabetes distress, that we will miss the context that may explain these problems. And I think that there is at least a good chance that for many individuals, or some individuals, that increased distress is a signal about problems that are beyond that individual's control. So to the extent that we continue to focus on interventions that are aiming at changing the individual's behavior over things they do have control about, we may all come up short. I think this is a time for us to reflect on this and to think about how we can do better. We proposed a model like this a few years ago working with Larry and Bill Polanski on this review paper, where we took this continuum view of depression or distress, severity, and thought that it could range from little or none all the way to severe presentations that might warrant a diagnosis, but that in each of those cases, the content or source, the context that might explain that emotional distress is as important to selecting the right treatment and intervention approach as the individual score on whatever scale you're using. So let's stop here with some implications and conclusions as we end up. So I think it's clear that clinical depression is important, treatable, and depressed patients are likely to benefit most in terms of their diabetes outcomes from integrative care. It's unlikely that just treating depression is going to result in as much of an influence on diabetes outcomes as we could get by integrating that kind of treatment with support for self-management and behavior change skills. It's also clear that diabetes distress is something different. It's more common, it's more likely to be chronic, and it's closely related to self-management and treatment outcomes in type 1 and type 2 diabetes. Routine screening may have unanticipated downsides. I think we've talked about that. And I think we're often confusing major depressive disorder with non-psychiatric emotional distress. And again, I think that's important because they require distinct treatment approaches, and distress could be a signal pointing to social determinants of health that are the true problems that need intervening upon. And just focusing on having people feel better about their problems may not go a long enough way to addressing those social determinants. And I think that's a growing awareness in the field, and hopefully that's something that we're going to have much more progress on in the coming years. So I'll point you to the Psychosocial Care for People with Diabetes position statement of the American Diabetes Association. This was really a landmark, and I think speaks to just how front and center these issues have become in comprehensive person-centered diabetes care. We again took a continuum approach to thinking about these problems, where all healthcare providers should be adept at dealing with emotional problems that come up over the different phases of living with diabetes, and then mental health or behavioral health specialists should be part of treatment teams to address more complex and more severe presentations of psychiatric disturbance. So the position statement did recommend routine monitoring of diabetes distress, and also recommended annual screening of people with diabetes for depression, but recognizing that further evaluation will be necessary. And hopefully I've further emphasized that point in the talk today. So some directions for the future. I think we need more information on the implementation, costs, and benefits of depression and distress screening in diabetes. I think there's a lot of excitement for these problems and for these programs, and a lot of agreement that these problems should be addressed through screening, but we actually have very little evidence about how these screening programs work in terms of improving care and what they do in terms of the scarce mental health resources that are available. I think we need greater precision in measurement. I think it's easy to stick with labels like clinical depression and think we've got that covered by our 9-item self-report scale that can be completed in a couple of minutes. But I think things are a bit more complex, and I've hoped to highlight that for you today. I think we also need to be looking at relationships over time. I mentioned the GRADE emotional distress study that I'm involved with through my collaboration with Andrea Charrington. There are other studies that I'm involved with looking at an intensive longitudinal design, trying to measure these things over the course of the day and across days over the week, asking people about their mood states, and then pairing that data with data from continuous glucose monitoring. I'm hoping that that can shed some new light on the directionality and causal influence of some of these relationships. And I know that others are involved in similar research as well. I think that's promising. I think it's clear that depression and distress are patient-centered outcomes of diabetes care, and we shouldn't just care about those outcomes to the extent that they have something to do with change in A1C. There is a benefit to treating depression. There is a benefit to reducing diabetes-related distress in terms of that patient's quality of life that don't need to be translated into A1C units to have any value. So I think that's something that's also important to remind ourselves of as we digest this literature. And I think, as I mentioned, there's an unmet need for sustainable, integrative care models that can be implemented in real-world practice. So I'll do another plug for the Diabetes in America book. This talk focused on adults and focused on type 2 diabetes in the interest of time, but we cover type 1 and type 2 and pediatrics as well in this chapter, thanks to help from Corey Hood and other co-authors here. And I have to do a final plug for the New York Regional Center for Diabetes Translation Research. Our focus is on taking this biopsychosocial approach that I've alluded to that considers context and focusing on health equity and reducing health disparities with a specific focus on the Latino population. And we are welcoming requests for consultation and opportunities for collaboration. So that's 45 minutes, and thank you, everybody.
Okay. So thank you, Dr. Gonzalez. That was an excellent presentation. I am actively thinking about how this information will inform the health equity research we are focusing on through our CDTR. But before I ask any questions of my own or open it up to audience questions, I would like to remind everyone of the next presentation in this webinar series by Dr. Anna Gloin. And you can see the title and date of Dr. Gloin's presentation on the screen now. As I mentioned at the beginning of the presentation, oh, sorry.
Can I just mention a few things about the upcoming, the fall seminar series, just briefly?
Sure.
So one thing that's going to be different in the fall is for those who are trainees, graduate students, medical students, postdocs, is we're going to have the opportunity for the trainees to meet with the speaker afterwards in a separate virtual meeting. So everyone who has registered previously, you'll get emails to register, but particularly if you're a trainee, the sooner you respond, the more likely you'll be able to be one of those that meet the speakers. We'll only have a limited number of slots for that. So we do ask people to go ahead and sign up earlier rather than later. We're also trying to consider how we might make it possible for faculty members to meet with the speaker, but we haven't worked out those logistics. But just keep that in mind. You'll get emails, and we're going to try and reach out to other DRCs and such. But just go ahead and start registering as soon as possible. Thank you.
Great, thanks. Okay, so as I mentioned at the beginning of the presentation, to ask a question, please click on the Q&A icon at the bottom of your Zoom screen and then type your question in the box. Once you're finished typing the question, raise your hand by clicking the raise hand icon. And when I call on you, open your microphone, which you will need to do in order to unmute your mic. So that's it. So I'm gonna open up and let's see. So we have a question, and then please pardon me if I mispronounce names. I want to try my best. So Jeff, this question comes from Tom Alassi, and he's asking if there are racial differences in depression or distress within diabetes. And maybe related to that, whether there are any differences with respect to socioeconomic status, health literacy, and numeracy with respect to diabetes and diabetes distress.
Yeah, great question. And the evidence is a little bit mixed in terms of whether there are ethnic racial differences versus socioeconomic differences. Oftentimes, study populations are confounded on those two variables, right? So we've certainly seen high rates of screening positive for depression and for diabetes distress, up to about a third of participants in some of the samples that we've recruited here in the Bronx in New York and throughout New York City with predominantly Latino and Black populations. But that does not put the prevalence out of the range that's been found for meta-analyses of the wider literature. There's been some indication through narrative reviews that levels of diabetes distress may be more common among minority populations and among those with poor socioeconomic status, but it hasn't been quite clear. And certainly we know that levels of depression outside of diabetes do not show any ethnic differences with respect to whites versus other minority groups. However, there is a super strong socioeconomic gradient, right? And that can sometimes, look like racial differences, especially with rates of problems among Native Americans, for example. Socioeconomics are probably driving those differences.
Great, thank you. All right, another question, Dr. Brownlee. This question is, many patients with diabetes are unaware of the increased cardiovascular disease risk associated with diabetes. A very small percentage of patients are currently meeting ADA recommendations for HbA1c, LDL cholesterol, and blood pressure levels. Why do you think that is? And what is the best way of improving these rates? Physician-focused interventions?
Well, that's a great question. It's a big question, and it's, I think, only sort of tangentially related to depression and distress and diabetes, but I can comment it from kind of the same perspective of experience of working in this area with patients. I can tell you, for example, in a recently completed telephonic self-management support intervention that we've done here in New York with the New York City Department of Health, we, like I said, found high levels of depression and distress, but we also found just poor levels of education. Again, maybe not so out of the norm for what we know from the national literature, but somewhere below 6 or 7% of our participants reported ever getting any diabetes education in the past prior to participation in this protocol. And when we asked them what did that education consist of, most often the answer was that, well, once my doctor tried to explain to me something about how to use insulin. So they were not referring to formal education that we talk about as a standard of care for all patients with diabetes. So education, I think, is one thing. I think it's also important to recognize that there is a disconnect between the person's experience in their day-to-day and that abstract blood panel value of their A1C level, right? Someone can be feeling just fine with an A1C of 8 or 9 and then experience side effects, maybe sexual dysfunction, maybe GI side effects, maybe a low blood sugar that really scares them when they are treated, right? So I think it's an inherently difficult problem to get people to care about risk markers for outcomes that are many years away. But I do think that behavioral science, behavioral research does have something to say about successful programs that can help by targeting patients, but also targeting providers. And again, to think more systemically here about the larger context, I think to really address this problem, we need to address gaps in access to healthcare, costs that are often associated with taking medications and other related problems at the level of the health system.
Great. Let me see. Any other questions? While I wait for that, oh, I see one here. Okay, this is from Jennifer Iyengar. I'm hoping I'm getting that right. Our clinic currently screens all young adults with diabetes for diabetes distress when they make the transition from pediatric to adult care. However, as a provider in clinic, it is sometimes difficult for me to know how I should respond when a patient has high distress on screening. Is there something practical I should do for these patients that is feasible in a 20-minute clinic visit?
Yeah, that's the question over and over again. I think, again, it's a reflection of a systems problem, right? Too little time for these visits with patients. But I think that one thing that the diabetes distress really does have an advantage for is that, the items on the scale are about problems. So even though we've tried to talk about diabetes distress as kind of an alternative to depression, it's about emotional distress that is specific to diabetes. It's different from depression in that it doesn't just ask about how badly you're feeling and what emotions you're feeling. It asks about worries that you have, concerns you have, feeling like my doctor doesn't spend enough time to answer my questions about diabetes, or something similar to that is an item on that measure, right? So I think that one thing that you can do in a screening program is to use the DDS as a jumping off point, or whatever scale you're using, as a jumping off point by looking at the most strongly endorsed items. So what are the items that are really causing or contributing to the person's distress? Bill Polanski's, I think, trademarked question here is, what drives you crazy about your diabetes? What drives you most crazy about your diabetes? And asking that question in a normalizing way that anticipates that there are plenty of things that can drive people crazy about their diabetes can be a good way to start a conversation. And I think it's also important to remind ourselves as providers that we don't have to finish every conversation we start in 20 minutes or in one visit. So this can be a conversation that continues across visits, can be something that the person follows up with through an education group that you could refer them to, a nurse educator that could do some more follow-up. But there could be specific problems that you can identify with a measure like this that you as a diabetes care provider would be most qualified to deal with.
That's great. Thank you so much. I'm not seeing any additional questions here. I'm trying to also be conscious of time. So let me just ask one last question because I don't see any here for you. So tell us what's next for you. So you mentioned a clinical trial that you're currently working on to try and sort of, disentangle some of these mechanisms. Is that the only thing that you're working on? Are there other things that we should?
Well, that's one that I'm really just excited about, because I could have never done that study on my own, right? That was just really being in the right place at the right time. And again, all thanks to Andrea Charrington for pushing it ahead. But that study takes advantage of a randomized controlled trial design that is just not available in any of these studies looking at the relationship between emotional distress and outcomes in diabetes, or emotional distress as an outcome of diabetes treatment. So that's something that I'm excited about. I'm also doing some great work with Beth Piatak and Donna Sprout-Metz at USC. They're also involved with us at the Center for Diabetes Translation Research at Einstein. And that's where we're using these sort of techie devices. We're using smartphone apps, activity monitors, and blood glucose monitoring, continuous glucose monitoring, to look in a short time frame of over 14 days, what happens to mood in response to blood glucose variations over the course of the day, and what happens to cognition and functioning, and how self-management may play a role there. So I'm increasingly interested in that study and a couple of other studies that we're trying to get started here in the Bronx to use this technology to kind of zoom in a little bit to the moment-to-moment relationships that should be observable if these correlational relationships that have been reported in the epidemiological literature really are causal relationships. That's another area that I'm excited about.
That's great. Thank you so much. So I'm going to ask Sean to come back on. I'm going to wrap up. Is that okay?
Yes.
Okay, great. So I'd like to thank everyone for joining us. If there are no other questions, then I think we'll wrap up for today. Thank you, Dr. Jeff Gonzalez, for this presentation. It was great. And I'm sure if there are further questions, they can contact you, and you're easy to find. I think they can get a hold of you. So thanks again, everyone, for joining, and we'll see you next time.